seara, stimați telespectatori! Bună seara, stimați invitați! Vă invităm în această seară să fiți alături de noi într-o discuție extraordinar de interesantă vis-a-vis de o patologie rară, dar poate rară prin subdiagnosticarea ei, și mă refer la hipertensiunea pulmonară. Din această mare categorie vom discuta în această seară împreună cu distinșii mei invitați despre grupul 4 al hipertensiunii pulmonare, respectiv hipertensiunea pulmonară cronică tromboembolică. Good evening, honorary professors. I have the pleasure and the honor to have here with me Professor Marcin Kurzyna, an expert in the field of pulmonary hypertension, especially and in chronic thromboembolic pulmonary hypertension. Professor Kurzyna is the head of Department of Cardiology at the European Health Center in Wrocław in Poland, and he is also the head of the Department of Pulmonary Circulation, Thromboembolic Disease and Cardiology. Welcome you, Professor.
Thank you very much. It's my great pleasure to be here.
Thank you so much. And also, Professor Dr. Iwan Cilea, it's the head of Internal Medical Clinic number 2, Emergency Clinic Hospital in Târgu Mureș, and also he's the coordinator of the Pulmonary Hypertension Center here in Târgu Mureș. It's one of the 7 centers of pulmonary hypertension in Romania. Good evening, professors.
Good evening, Andrea. Nice to meet you again, and I hope that we will have an enjoyable evening in the next minutes, and we will discuss together regarding the chronic thromboembolic pulmonary hypertension, and of course we'll offer to the audience the best of our knowledge.
Thank you so much. It is going to be a challenge to have a short time to discuss about such an extended and such an important topic. But first I would like to ask you what is the reason of this meeting? How come that we are here all three together?
I think the main reason that we are here is our common interest in the pulmonary hypertension. Pulmonary hypertension is a rare disease, but rare diseases are now very, very well recognized by the European community because taking care about patients with rare diseases is an important point of the European healthcare, and it is facilitated, and we are here to cooperate between countries because rare disease means that number of patients is relatively rare in every country. But if we will combine our efforts, we are able to collect experience, to introduce new techniques, new drugs, and so on. So I think our common interest is a main reason that we are here, and thank you very much for this very kind invitation.
Thank you for the acceptance. Professor.
The reason of this meeting is a fantastic one. I think that we start the collaboration between the Excellence Center in Wrocław in Polonia from many years ago with very small steps, and now we develop a very good collaboration in the medical field and in the scientific field. And I hope with the great support of Professor Kurzyna, the pulmonary hypertension, and especially the chronic thromboembolic pulmonary hypertension, diagnosis and treatment will be at high levels here in Romania. Of course, we want to share our experience with them, and we want to be a part of a network of an European network. And Professor Kurzyna and his team is also a part of the European network in pulmonary hypertension.
Thank you so much. What about pulmonary hypertension? We all know that it's a rare disease. We've already know that it belongs to 5 groups, like in clinical classification. Can maybe describe a little bit what are the signs? Like, where do we start with chronic thromboembolic pulmonary hypertension?
Chronic thromboembolic pulmonary hypertension is in fact rare disease, but it is a sequel of very common disease. I mean about acute pulmonary embolism. Acute pulmonary embolism is a life-threatening condition. Many patients is suffering from that, and about 2, maybe 3% of them in the future, despite proper therapy, developed pulmonary hypertension caused by the organized clots, which are not dissolving after the treatment, but changing into the fibrous, well-organized tissue, which is an obstacle for the flow through pulmonary arteries, and it makes elevation of the pressure in pulmonary artery, and finally results in development of right heart failure. So this is maybe rare but very serious condition, and there are several methods of therapy. But the additional reason that we are here, that we are developing new technique of the treatment of chronic thromboembolic pulmonary hypertension by methods known from the interventional cardiology, for example, used in the treatment of acute myocardial infarction.
Okay, that's a very good and a very important step in treating these patients, because at this point we know that this disease has two approaches in treatment. One with a specific therapy, specific medication, and maybe Professor would like to add something to this topic, and also interventional one, and maybe you would want to develop it. So let's start with the medical treatment. What can we do for these patients?
Before I will speak about medical treatment, let's say the truth. The truth regarding this fabulous day, this marvelous day, because in this day, with the great support of my colleague, Professor Kurzyna, we started in Romania the possibility to treat the patient with CTEPH more efficiently than with the drugs, than with the pills. So this morning we performed a very successful procedure of balloon pulmonary angioplasty, as I told you before, with the support of Professor Kurzyna, also in decision to select the case. So we are the first here in Romania performing this procedure, and we hope that we'll be in the future an excellent center and a reference center for the Romanian patients. Regarding the treatment, yes, it's interesting because, as my colleague told before, we have a lot of signs and symptoms related to the right heart failure. So it's not. It's necessary to recognize the right heart failure and the symptoms and signs of CTEPH, and to have a very correct diagnosis. What we done till yesterday in Romania was just medical treatment. Medical treatment, that means targeted medical treatment regarding the use of riociguat, that riociguat is soluble guanylate cyclase, and also the anticoagulation. This medical treatment is feasible for patients which are inoperable, or patients who develop pulmonary hypertension, or who have persistent pulmonary hypertension after the thromboenterectomy. But when we work together, BPA, balloon pulmonary angioplasty, and drugs, the quality of life of the patient and the life expectancy increase. And also, I think that these are the big steps that we started in this day in Târgu Mureș in Romania.
So apart from this specific targeted medical therapy with riociguat, we also have the interventional procedure, which could be pulmonary endarterectomy, such as known as PA, but maybe not all the percentage of patients will benefit, or they will be suitable because of the, I don't know, maybe comorbidities. What about the rest? Should you address them to the pulmonary, to the BPA, so balloon pulmonary angioplasty? Should you take?
This is the option, I mean, about balloon pulmonary angioplasty, which is dedicated to people who cannot benefit from the surgery, because surgery is still considered as a first-line therapy, but the requirements for the surgery are very specific, because the clots must be located in the big arteries to allow surgeon to pick them up
proximal
from
to the
proximal. I mean about main pulmonary artery, lobar pulmonary artery, and additional factor is that patients must be relatively healthy. I mean healthy, so the patients without comorbidities. But chronic thromboembolic pulmonary hypertension is often the disease of the older people with many comorbidities. So taking all those together, about 50% of patients cannot be operated by the surgeon. So BPA is the option for this population to offer them mechanical declotting, mechanical opening the pulmonary arteries. And this technique is really amazing. I am a big fan of this. We started performing BPA in our centers 10 years ago. And till now, we perform more than 1,000 procedures in more than 200 patients. So our experience is quite good, I think. And it's my great pleasure to share this experience with Professor Tilea and his team. And it was also great pleasure to support Professor Tilea in performing of BPA, because you were the main operator and I only supported you, and I was I admired your skillful in the interventional cardiology, because it's some kind of the basic. It must be person who is experiencing the interventional cardiology and some additional knowledge and experience which makes this procedure a little bit different than intervention in coronary arteries or peripheral arteries.
Before discussing the technical details, how do you think, or do we think of a patient with, let's say, suppose that he's already diagnosed? Should we think therapy, or should we choose, or should we offer to our patient both methods?
I think that we need a very good collaboration. That means the CTF team must exist. What means the CTF team? Means the cardiologist, the clinical cardiologist, who is responsible for the non-invasive diagnosis. Also the interventionalist, who is responsible for right heart catheterization, and maybe he will assume the BPA procedure, and also the surgeon, the cardiac surgeon or the cardiovascular surgeon, who will decide if the patient is suitable for PA or not. So as Professor Kurzyna told before, about 50% are not suitable for surgery. So there remains a lot of patients who are feasible for BPA or just for specific targeted medical therapy for Rio-Chiguat, because maybe you know, or maybe we can inform our auditorium that Rio-Chiguat has class 1 indication in the European guidelines for treating chronic thromboembolic pulmonary hypertension. So this is the decision. We have a good diagnosis in the excellence center, that in excellence center or in expert center, as we have here in our clinic, it's mandatory to have also a very close collaboration with a radiological team who is very familiar with scans, with reconstructions, to offer the best anatomical information regarding the localization of the clot. Because if the clot is in the main pulmonary arteries, as Professor Kurzyna told you, or in the big pulmonary arteries, on the big branches, the case is almost surgical. But if the clot is located into the segmental arteries,
so distal, more distal,
or distal, this is suitable for BPA procedure and also for drugs.
So the message that we should address to our auditorium is that these patients, after having a clear diagnosis, is that they should be directed to both therapies, medical therapy, but also together with the possibility to have a BPA, if not suitable for surgery. Okay, so up to this moment, to my knowledge, I'm also working in the team, we didn't perform that option. So it's a pity not to access this highly standard procedure, because it gives to our patients, of course, the chance to survive. Is it a curable procedure?
In some cases, yes, because you know it depends on the mainly comorbidities and the time in which the disease is developing. The longer time, the less possibility to cure completely. But it is the procedure which is very important for patients because it decreases parameters of pulmonary circulation, hemodynamics parameters, but also decrease the signs of the right heart failure and very importantly increase the quality of life. So this procedure fill the gap of the whole spectrum of treatment of chronic thromboembolic pulmonary hypertension. So I mean that the main message from our talk here should be like that if you have a patient after pulmonary embolism with persistent dyspnea, with exercise intolerance, with signs of right heart failure, you should refer such patient to center which is specialized in pulmonary hypertension. It is very important in rare disease that healthcare should be focused in the very specialized center because it's a reason
people
that
who are expert
yes,
in this field, such as in Târgu Mureș.
Yes, that's
we are
right.
working in this center, and of course it requires a special training, but also up to the moment where we send the patient to have the procedure, but also to follow up these patients. So thank you for this message. It's very important for the auditorium and also for the message to carry out that these patients do need support and they can benefit for this procedure. What about technical details? Wow, let's maybe somebody we all know, but maybe let's.
I don't know whether it is easy or difficult.
Is it? Yes?
No, for me it's not difficult to explain the technical details, but I invite you to offer the best informations regarding the technical details. But it's very important for the patients and also for the families, as also for the treating doctors of those patients to know and to be informed that the BPA procedure is not performed in just a single session. Because usually, or so in the most of the cases, there are a lot of vascular arteries obstructed by clots. So if we need or we want to obtain a good quality of life of the patient, if we want to improve the hemodynamic parameters and we want really to treat the patient, we must have a discussion before starting the procedure that will be a serial procedure repeated at intervals, and Professor Kurzyna will inform you about the technical details and how it's indicated, the procedure, when it's indicated, and when the procedure should be performed again. Please.
Maybe before I will do it, I have such comparison, because if you are dealing with coronary artery disease and we have lesions in 3 arteries, we are talking about multi-vessel disease. We can imagine that in the lungs, we are dealing with 20, 30 lesions located in the all obstructions located in the very different parts of the lung, and we have to deal with it. And it is impossible to do it during one session because of issue of contrast, radiation, and also a fear of the reperfusion edema when we start the flow in the area which did not work before. It may be some problem. So this is the staged procedure. The mean number of sessions in Poland is about 5 and 6. So it must be repeated every 1 month. And at the end of the cycle of treatment, we may expect that the drop in pulmonary arterial pressure is very significant. Sometimes it's normalization. Some young women decide after the treatment to be pregnant, which was impossible before because pH is strong.
We know that this, yes, it's a strong
for that. But getting back to the technical issues, for the first glance, it's a typical vascular angioplasty, balloon angioplasty, which is very well known from the other vascular territories. But the problem is complex anatomy of the pulmonary arteries. There's many branches, so you must be familiar with that. You must be prepared for that, with analyzing of the images coming from computed tomography, angiography, lung scintigraphy. So the imaging before this procedure must be very extensive, and it gives you opportunity to perform complete pulmonary revascularization, because it is our target. Of course, there are some special requirements regarding the vascular sheets, guiding catheter, guide wires, but at the end of the day, we are dealing with the equipment which is very well known from the angioplasties in other vessels. We must be very careful, because every mistake might cause the bleeding to the lung tissue. There is big airspace around the vessel, so the blood flow must be very rapid, and it can be detrimental for the patient, because it aggravates respiratory failure and right heart failure. So it must be done very carefully, and your experience is very important.
But what about reperfusion edema? Because some patients or doctors are afraid that after we disobstruct the vessel, the patient will develop the reperfusion edema.
The reperfusion edema, of course, our concern during procedure, especially when a patient has high pulmonary arterial pressure, because when we deobstruct it, the flow must be very rapid. But there is also a solution for that. During this stage procedures, we start from the smaller, undersized balloon to give opportunity to restore flow in step by step, to increase our hole, and when the mean PAP is lowering down at the end of the cycle of the treatment, we perform optimization of these lesions. The stenting is not necessary, so we may perform several dilatation with increasing size of balloon during the next sessions.
So regarding these topics presented by my colleague, I think that we must increase the awareness of the entire population and of the doctors regarding this disease, because if the patient is admitted in advanced right heart failure or in advanced and compromised hemodynamics, that means high pulmonary vascular resistance or high mean pulmonary arterial pressure, means that the procedure can be unsuccessful or maybe can be dangerous. So my message to everybody is to collaborate with us and to have a strict follow-up of the patients with previous pulmonary embolism, or to diagnose correctly in ambulatory settings or in the hospital settings the etiology of the pulmonary embolism, because as we know, some diseases are related to the etiology of pulmonary embolism.
It's very important to have the etiology, because we will address to these sessions of pulmonary balloon angioplasty specific the group 4, so the chronic thromboembolic pulmonary hypertension. For all the rest,
and do not forget about the lifelong anticoagulation. Even after your procedure, anticoagulation is indicated, Marcin? Yes or no?
Yes. But we use standard anticoagulation as in all patients with chronic thromboembolic PH, because it's per se indication for.
And should we keep the specific targeted therapy?
Yes, we should. I think
that's also an important aspect.
The good message is that we do not need antiplatelets agents, so we do not increase the risk of bleeding.
It's not a stenting, as you mentioned. It's just a balloon dilatation.
It's only balloon dilatation, but we should keep the anticoagulation in the very strict manner, and also we should keep the targeted therapy, because pre-treatment with targeted therapy like riociguat is decreasing the number of complications during the BPA. And after BPA, this is also additional therapy which is needed for long-term survival in good quality of life.
So I ask this question because most of the patients are afraid about interventional procedure, but this is about increasing the quality of life for our patients after having a correct diagnostic, as you mentioned, with a fantastic imaging support, because this is, and the gold standard diagnostic with the right heart catheterization, which is also available here in our center. Then we should identify, we have the clinical classification, choose the right patient for the right treatment. So most of the patients are afraid about the interventional procedure, but it's safe,
It is safe procedure. In the worldwide is developed through last 15 years, mainly by Japanese colleagues, and now the number of complications during the peri-procedural period is relatively low. The mortality in Polish registry is less than 2%, and in the international BPA registry, which were conducted in the most experienced centers worldwide, the mortality in peri-procedural period was 0. So in the experienced hands, it is very safe procedure. Of course, we should keep in mind that if patients is in more severe advanced stage of the disease, the risk is higher, but still the risk-benefit ratio is definitely shift toward the benefit.
What I want to mention, is the position of the Professor Kurzyna and his center among worldwide centers. That means experience. If I'm okay, I know that your center and your experience is between the 5 worldwide, something like this.
It's very difficult to count, but in fact we are among the biggest BPA centers in worldwide.
Worldwide.
We have a very good.
So I think that we have very good support, because is the biggest center in Europe. In the name of the patient, in the counting the number of the patients.
Maybe not biggest, because in Poland 8 centers is performing BPA. Our center is definitely biggest in Poland, and probably in the first 2 or 3 centers in Europe.
So it's a great honor to have you here and to open this pathway, because we need this for our patients. And together with Professor Tila, we will definitely work together to support this collaboration. Me from the clinical part with the diagnostic and then follow up, but definitely for the interventional procedure, to build a team and to get in line with the recommendations. You mentioned something very important, Professor, about the awareness and about the stage of our patients. I mean, most of the time this disease is diagnosed very late in their lives. Whom should we address to maybe, I don't know, increase or screen or have a diagnostic or sooner diagnostic? Is it something that, is it in our cardiologists, clinical cardiologists, the power to do, or should it be?
I think that the awareness related to chronic thromboembolic pulmonary hypertension, and of course pulmonary hypertension, must start from the general practitioner and also from the patient and family point of view, that if an unexplained dyspnea, even it's secondary after an acute PE, a dyspnea, some fatigue or leg swallowing, or in a patient with a history of splenectomy, or in a patient with a family history of thrombophilia. Such patients must be very well investigated in centers. And another step in the diagnosis of PH is a very common and used step here in Romania, an echocardiography. When we have signs of pulmonary hypertension on echo, some signs related to the dimensions of the right cavities and the hemodynamics counted the velocity in the pulmonary artery, or if we find a patient with a tricuspid regurgitation, with a mild, moderate or severe tricuspid regurgitation, please think about the pH and obtain an opinion from the expert center from here, from Târgu Mureș, if this patient is feasible. So think very well about this so-called unexplained dyspnea in a patient with potential risk factors or a personal history of DVT, that means deep venous thrombosis, or other hematological disease.
Such as thrombophilia, for example, high-risk patients?
High-risk patients for thrombophilia, okay.
So we all agree, and also the European Society of Cardiology, together with the European Respiratory, but also the American Society, do strongly support the role of PH expert centers. I mean, in these centers, there are cardiologists, such as each of us, that can deal with these patients. So the message would be to address these patients to specialized doctor cardiologists that are treating these patients. In Târgu Mureș, in our center, I think we are now dealing with more than 59 patients, I think, different etiologies of pulmonary hypertension. But now we have a new, let's say,
team member,
yes, thank you.
Pleasure is mine.
And also a new opportunity for treating those some of our patients. So we are very honored to have this collaboration and to know for also the audience that the procedure is in premiere was done in Târgu Mureș, and the patients will also be very happy to benefit from in near future of this procedure.
It was first patient, but definitely not the last one.
Definitely. I want to mention also something very from our inside collaboration and work. After 20 minutes, the procedure was performed. So the patient is not under anesthesia or something. It took 1 hour and a half. And after 20 minutes, the patient actually mentioned that she was very afraid. She was scared. But after 20 minutes, she decided that she will definitely want now the schedule for the next procedure. So it's hope. They do. If you have a good patient, educated patient, I think we can do a lot of things, good things for these patients. What's your opinion? I think it's a great start together. Okay, so thank you so much for this interview, and thank you so much for this collaboration. Thank you for the honor to work in such a wonderful team and high standard knowledge and high standard education in pulmonary hypertension, and especially in chronic thromboembolic team. I hope, as you mentioned, it's going to be, again, respecting the cycle of treatment for these patients. We thank you so much. Thank you so much, Professor Țilea. If there is something else that you want to salute or to address to the audience.
Thank you very much for the invitation here to Târgu Mureș. I found here people who are fascinating with pH, with very high scientific and clinical level. So it's my great pleasure to collaborate with you, and I believe that the collaboration will develop between us personal, but also between our institutions as well.
It is very important aspect to include also the university and the level of teaching in this field. And as you mentioned, in near future, let's hope that we will also have and develop a very good collaboration, but also in the research area with our support and facilities from the university. Thank you so much.
Today was a great day. I think that in this day, with the great help of Professor Kurzyna and his team, and also I want to mention the great support of the former director of the pulmonary hypertension unit, Professor Adam Torbitsky. With their help, we put this medical center and this university in the galaxy of the centers which are able to perform a good diagnosis and modern and optimal treatment of chronic thromboembolic pulmonary hypertension. I'm convinced that our collaboration will increase very quickly, because the information that we share with you and auditorium will arrive in good minds, in open minds of the doctors, of the patient, and the access to our center will be is very facile, and will make all the steps using the recommendation from the European guidelines to have a good diagnosis and to offer the patient in time, I repeat, in time, not too late, the possibility to treat his or her chronic thromboembolic pulmonary hypertension with targeted medical therapy, anticoagulation, and of course with balloon pulmonary angioplasty.
Thank you
Thanks
so
a
much.
lot.
Thank you. It was an honor and a pleasure to have this interview. Vă mulțumim foarte mult pentru audiență. Sperăm că am adus în vizorul dumneavoastră specialiști sau pacienți, de ce nu, o patologie rară la nivel mondial, diagnosticată cam 1% din procentul global, dar cu o importanță deosebită. Rata de supraviețuire a acestor pacienți diagnosticați este una prezervată. Hipertensiunea pulmonară are o evoluție severă. La fel ca și cancerul, este o boală care ucide. Este o boală care ucide netratată și neinvestigată suficient și la timp. Vă mulțumim tare mult, la revedere!